Alrighty, Alan. I think we are good to get going.
All right. Well, thank you so much, Liv. Welcome, everyone. I apologize that my camera seems to have malfunctioned, but I'm excited to be here with everyone. So um, we can go on to the next slide. Just first of all, I just want to introduce myself. I'm Alan Litwin. I am the Chief Scientific Officer of Prisma Health and also serve as the Executive Director of the Prisma Health Addiction Medicine Center uh, and a multi-PI together with Dr. John Ward, who's here today for the Hero in Practice study. And some basic housekeeping and participation. Keep your microphone on mute when not speaking. Turn your webcam on if comfortable. Use the chat function to ask questions and as always, respect diverse experiences and perspectives. And any technical issues, drop a message in the chat. Next slide. All right, so let's talk about what we're going to experience today for today's webinar. We can go to the next slide. All right, so I'm going to do a 20-minute welcome and introductions and an overview of INSU and our education programs, and then highlight some high-level lessons for HERO and an overview of the HERO in Practice project. From there, session one will entail hepatitis C epidemiology, simplification, and testing, and patient engagement and care. And we'll have several speakers I'll introduce in a moment. And then after a 10-minute break, that session will be approximately an hour, maybe just a tad bit more. And then we'll have a 10-minute break and then come back for a 45-minute breakout session with HCV champion navigators from different sites. And if we go to the second page of the overview, we can see we'll finish up with a session 3 report back. And then Liv Dawson, as the programs and policy manager for INSU, will do the wrap up and close and where we're going from here. Move to the next slide. All right, so I just want to introduce our speakers who you'll see. It's Dr. John Ward, Director of Coalition for Global Hepatitis Elimination, the Task Force for Global Health. We have Dr. Stacy Truskin, Chief Medical Officer of Mazzoni Center, Dr. Jocelyn James, Associate Professor of Medicine, University of Washington, Mr. Russell Sandvold, Lead Care Coordinator for the Hepatitis Education Project, and Dr. Shon Faladi-Nuia, Associate Professor, Division of Infectious Diseases at Johns Hopkins. In addition, we have 4 of our navigators with us today for the breakout sessions, Katie Kitzmiller, Brianna Brophy, Wes Wampler, and Morgan Davis. Next slide. All right, I'm just going to give you a little bit about INSU and INSU education programs, the International Network on Health and Hepatitis in Substance Users. So it's a global network of people dedicated to improving the health of people who use drugs. Our vision is a world where people who use drugs have equitable access to evidence-based services, treatment, and support needed to improve health and live well. We're a not-for-profit global network of members and collaborators. Our work focuses on hepatitis C, but also other infectious diseases and harms related to drug use, and spans knowledge exchange, education, and advocacy. And finally, we're governed by the General Assembly of Members and an executive board, and our work is carried out by the INSU Secretariat. Next slide. Okay, so today's program, INSU is supporting the Hero in Practice initiative, which we're very grateful for. And this is the largest program in the United States focused on evaluating models of hepatitis C, HCV care for people who inject drugs. Hero in Practice is being delivered as a partnership with the Coalition for Global Hepatitis Elimination and Prisma Health, building on proven patient-centered approaches to screening, care, and treatment for this priority population. And as part of this support, INSU is delivering 2 virtual training webinars. This is the first as part of our established United States HCV Intervention Symposium series that's been going on for some time, several years. And each webinar will include expert-led presentation on evidence-based interventions for HCV and peer learning and discussion to support shared problem solving. All right, next slide. All right, let's get into HERO in Practice. So based on findings from the HERO study, HERO in Practice is going to help the United States achieve HCV elimination goals, leading to decreased overall HCV prevalence and incidence, increased number of active people who are injecting drugs who are treated and cured of HCV, reduced HCV-related morbidity and mortality and improved the overall health of people who inject drugs. Next slide. And this is just a high level. We don't have time to get into all the results, but prior findings from the HERO, which is published now in 20 papers, the primary outcomes paper in the Lancet, one of the Lancet family journals, gastro and hepatology. And you can see overall, we enrolled over 700 people actively injecting drugs, 623 initiated treatment, and we have various populations in the ITT, the modified ITT and per protocol population. We had two arms, the modified DOT and patient navigation. So individuals were randomized to one of these two arms in two different settings, either methadone treatment programs or community health centers, if you can just go back to the previous slide. And so we could see that overall, there were no differences between the two arms, whether it was patient navigation in the kind of lighter color or the modified directly observed treatment. And in the modified intent to treat population in the middle, which was all the individuals who initiated treatment, you can see about 75% initiated treatment. Achieved SVR or cure in both arms. The majority of those who didn't achieve cure were lost to follow-up. And the per protocol population on the right, which only looked at those who had SVR ascertained, we could see about 92% cure rates. And so that over 90%. And then if we go to the next slide, we can talk a little bit about, the settings. Again, 23 different sites in 8 U.S. cities. And we talked about the randomization, and all individuals received sofosbuvir in combination with velpatasvir for 12 weeks. Again, navigators, which is key to HERO in practice, coordinated the HCV treatment, offered health education, assisted participants to overcome barriers, and provided psychosocial and adherence support. Look at the next arm. Next slide, rather. One of the other top line, other than in the per protocol, more than 90% achieving cure, this was a really important finding published in Journal of Hepatology, which showed that the adherence was somewhat forgiving. And you can see, because we leveraged these electronic blister packs that included all 84 doses across 6 different weeks, blister packs. In some cases, they're weekly blister packs, and you could they were wired up so that if you popped out the pill, you could see the exact day and time, and so we could look at very fine measures of adherence and look at the association of adherence with cure. And you could see on the right in the blue, even when you got down to 50% adherence, 98% of those 43 individuals were able to achieve SVR, and so all of those who achieved at least 50% adherence in the bottom, they all achieved SVR 12 over 90% as a group. And even as you go to the left, certainly lower SVR, but it was still the majority achieving cure, even with very low rates of adherence. And also within that, but not shown here, even with treatment interruptions of a week or 2 weeks, people did quite well. And it was most important that people were able to complete treatment or get to the 3rd month of treatment in this 12-week course. You'd have a 95% cure rate, but lower cure rates if you discontinued in the first 2 months. And finally, some other patient-reported outcomes. We found that individuals who achieved SVR or cure were more likely to have improvement in depression, anxiety, chronic pain for those who had higher levels of pain, had changes in different behaviors, including less injection drug use despite continuing to use drugs, less sharing behaviors, less alcohol use. And so lots of important findings beyond SVR and adherence. Okay, we can move on to the next slide. So I'm going to talk about in a few slides here, HERO in practice. And again, this is exciting because, HERO and many other studies now have shown that people who inject drugs can achieve high levels of cure and fairly low levels of reinfection. But the key here is really, how do we scale this up? And so we believe that HERO in practice is going to be a good foundation and an ecosystem and a platform for helping to scale elimination programs that serve people who inject drugs. We have 60 sites and across various settings of care. We've now expanded in HEROs in practice from methadone programs and community health centers, which are very important, to other patient-centered medical homes serving people who inject drugs, including rural clinics, other addiction programs, not just opioid treatment programs, mobile health and street medicine programs to get to individuals closer to where they reside, even in, if they're marginally housed, in service programs, and as well as correctional facilities, both jails as well as prisons. In terms of scaling, again, this is not a research study. We've already established that we can treat people who inject drugs, but we are rigorously evaluating and employing a step wedge design where we have several different rolling outs, different geographic areas sequentially, so we can evaluate how we're doing. Trainings like today, very important, and a second one, and there'll be another one in person that's optional for those who can make it on the East Coast. This is the INHSU curriculum, as well as New York State Department of Health are partnering. They have a really robust set of curricula for patient navigators that we believe are going to be very, very helpful. Because again, patient navigators is the intervention that we've chosen based on the results of our study, but also some of the qualitative data that seem to point to that as being a preferred option. A key strategy is implementation facilitation. So we're going to develop site-specific toolkits for each of the settings on the left. So an overall implementation, but really each of these settings has unique considerations and opportunities, but also challenges. And so we believe it's important to have these site-specific toolkits, and then offering technical assistance, both real-time clinical expertise, but really TA on how to integrate. And finally, communities of practice, which will, and many of these aspects will be led by the Coalition of Global Hepatitis Elimination, including the communities of practice. And our outcomes are simple. We want to minimize the burden of data collection, but looking at really initiation, completion, and cure rates for the group that gets treated. And again, this is a real world project, so people will be treated with whichever regimens are available. Some states there may not be multiple regimens, but through a shared decision making, the key here is achieving cure. Okay, we'll move to the next slide. Just a little bit more about some of the design and key activities. So we have 4 different phases. Can be a little hard to remember the different phases, and not so important if you're doing the work at each of the sites, but just wanted to break it down. For usual care is a pre-implementation quantitative survey and a qualitative interview. We're developing REDCap databases, so just education on the basic data collection, and some baseline data collection, and then trainings like this today. During the active phase, which is called the implementation facilitation phase, this will actually be led by Dr. Sean Faladi-Nwia's team out of Johns Hopkins. And there's going to be monthly implementation facilitation meetings virtually, ongoing data collection, and monthly TA available, as well as monthly site level surveys. And all of these will be as little burden as possible. Then post 12 months is the maintenance phase, so post implementation qualitative interview, continued data collection, and the continued monthly site level surveys. That should take very little time. And finally, ongoing throughout all of this, we'll have additional trainings by INHSU education. Really at the core is going to be monthly communities of practice, both a national for the whole project, but also site specific. And we will open this up to folks beyond Hero in Practice, and also hope to be able to expand the network of Hero in Practice, because we know we have a 20-year period in which we want to achieve elimination and get much closer and achieve the targets. Again, at 8 warm line access, and then as we like to do with all of our PCORI studies and projects, is quarterly national and patient stakeholder calls. We already convened our first patient stakeholder group to get input on what we're doing, and a national one will be forthcoming, and those activities led by the coalition. You can go to the next slide. Okay, so here's the Hero in Practice team, and there's many others as well, but you can see John and I serving as multi-PIs, Prisma Health, Ashley King, and Dr. Carolyn Hoflich, the coalition, in addition to John, Lindsay, Hebert Suwando, and Quincy Williams. And again, we have an important group of investigators, many who are part of HERO, and leaders at Johns Hopkins, Sean Faladi-Nwia, Dr. Shruti Mehta, Maria Latimer, and Tracy Agee. West Virginia's Judith Feinberg, Lynn Taylor, to Health First and FQHC in Rhode Island. Judith Suey and Jocelyn James. Jocelyn's here today. University of Washington, UMass, Allison Carraz, Amazonia again, Stacy Truskin, and at Clemson, Moonsung Hio, and finally Miranda Gormley at Prisma Health. And Ashley King is our project director, overall project director, along with Lindsay. So you can reach out at any time with further questions. So about the symposia program, we can move forward for the last final slides here. Okay, so as you can see, it's been several years at Liv and team, and many of us have been privileged to be part of it. But it was 15 plus, I think, it might be 17 different cities and around the country, at least, and growing, trying to get a good representation from all regions in the Midwest and East and South and West Coast and so forth. So really proud of all of these in-person seminars. And the format is usually the standard format is a face-to-face symposium, so interactive face-to-face symposia, highly tailored, locally relevant sessions. So really working with local leaders who are championing and leading efforts locally and regionally and sometimes nationally, but really need that local context and group work discussions to facilitate interactivity. It's all about the interaction. And then the communities of practice that are a part of that as well. And this is the INSU Symposia, is dissemination of resources post-symposium. So it's not just a one-off. And then other webinars and linkage to ongoing support. And then a second webinar, again, is scheduled for August for those who could not attend this one. And again, a little different. Again, this is in conjunction with the communities of practice that Dr. Ward and team are going to be leading for Hero in Practice. Maybe, just to kind of highlight that. Okay, we are going to the next slide. All right, and then the Hepatitis C Intervention Toolkit. This is an online toolkit profiling a range of evidence-based interventions to enhance the HCV care cascade. Really nicely done. How-to guides on different types of modalities and interventions, including dry blood spot testing, point-of-care antibody testing, point-of-care RNA testing, which is fairly new, about a year approved in the United States, peer support, patient navigation, and medical record auditing for HCV, so leveraging the EHR for screening and even looking at cascade of care. You can also search the toolkit for our models of care infographics and connecting with care films that are really well done as well. So definitely take a look. You can see the link there and see all the great materials, and it's always being updated and added to. Okay. I think obviously acknowledging INSU in collaboration with the Coalition for Global Hepatitis Elimination, which is a program of the Task Force for Global Health, as well as NASTAD and Prisma Health. And then finally, we want to acknowledge our sponsors, AbbVie and Gilead. And again, the sponsors have no control over the content of the program. And we want to thank our endorsing organizations. So a lot of different organizations, all of which you can see here, and also growing. Again, so important that we work not just with local champions and leaders, but also local organizations and some national organizations as well. All right. Well, with that, I believe I will be turning it over to, we can look at the next slide, Dr. John Ward, who will discuss epidemiology, global, regional, and national epidemiology of hepatitis C.
Excellent. Thank you, Alan. Good day, everyone. It's great to be part of this webinar. And my task, which I'm happy to accept, is to give you an update about the epidemiology at the global, regional, and national level of hepatitis C infection. Next slide, please. The data for global epidemiology comes from a recent global report for the year 2024 put together by the World Health Organization. So that's available on their website. So you can go there for further exploration of these trends. But based on the WHO report, they estimate about 47 million persons are chronically infected with hepatitis C around the world. From the benchmark year of 2015, when WHO set goals for the elimination of hepatitis C, with a 90% reduction in incidence, 65% reduction in mortality, you see that they estimate about a 20% decline in prevalence which is indeed good news. But we would like that trend to be even steeper over these years, and we hope to contribute to declines in the future. Next slide, please. As far as new infections, they estimate about 900,000 new HCV infections globally. You see, there hasn't been, in their estimation, has not been much of a decline in new HCV infections around the world. The line graphs to your right are for the different WHO regions, of which there are 6. If you look at the top line in the middle, you'll see the trend for the Americas, and you see that incidence rate is going up, in contrast to flat or slight decreases in the other regions. And as I'll show you in a moment, that's principally because of trends in the United States. Next slide, please. As I believe most people on this call will know that the people who inject drugs are the population at the highest risk of hepatitis C infection around the world. In this particular estimation, about 50% of people who inject drugs have been infected with hepatitis C. That prevalence can be much higher in many settings. And because people who inject drugs are often incarcerated, it contributes to high prevalence among incarcerated populations. Again, in this particular estimation of about 18% prevalence globally. Again, with wide differences, at the local level. Next slide, please. This is a very interesting model that was published over the last year or so, looking at trends in new annual HCV infections contributed to injection drug use. As you see here, they were estimating that there were about a little over 800,000 new HCV infections. But what I found particularly relevant for our discussion today is look at the number that they attribute coming from the United States, almost 370,000, or more than 1 out of every 3 new HCV infections are among persons in the United States. So the U.S. is very much contributing to the global epidemic of HCV. And so when we think about global HCV elimination, we have to do our part to reduce transmission of HCV infection in the United States. And that's one of the goals of HERO in practice. Next slide, please. For mortality, WHO estimates about a 12% decline. So we're not close to that 65% reduction target by 2030 yet. You see there have been some decreases in the Americas, and you see there on the top line, with the largest declines in the Eastern Mediterranean region, which includes Egypt, which I'll give you an example of a model program in that country here in a moment. Next slide, please. A big challenge around the world is the fact that just most people with current HCV infection are unaware of their infection, are not being referred for care, and are not receiving the curative treatment for their infection. And that's our big challenge. And that's what we're seeking to improve through HERO in practice for people who inject drugs in the United States. Next slide, please. Let me give you 2 examples of effective programming for hepatitis C elimination. Let's start with England. We put together the components of an effective program, starting with a national plan, setting national elimination targets, having reliable data to monitor trends in hepatitis C burden, transmission, and mortality. If you look in the middle column, you see that they took steps to simplify their care cascade with reduction in the number of clinical visits, making treatment available beyond specialty care. And as you can see there at the top of the middle column, achieving high rates of diagnosis and linkage to care, and initiation of curative HCV treatment. And as a result, if you look to your right, you can see they are, with their reliable data, they can document large declines in viremic infections, including among people who inject drugs, and large declines in HCV-related mortality. And so that, and then at the very bottom of this slide, you see that simplification of HCV care and treatment was joined by scale up of access to clean injection equipment and to drug treatment. Next slide, please. Egypt, it's very difficult to have a talk about HCV without mentioning Egypt. A low and middle income country, once the country with the highest prevalence of hepatitis C of about 10% because of unsafe injection practices in healthcare over several decades. But they made a commitment about 7 years ago now to test every adult in the country for hepatitis C using a variety of different strategies in communities and in clinics, having a good referral system to refer those persons on to treatment sites, all without any patient cost, and achieved great acceptance of that program by the population. And they estimate they have declined from a 10% prevalence to about a 0.5% prevalence after treating over 5 million people for hepatitis C. So they put together a highly effective program. And to date, they're the only country that has been recognized by WHO as achieving this gold tier progress toward the final goals for hepatitis C elimination. So it really just stresses the importance of a political commitment to put effective programs together. And that's what we need here in the United States. Next slide, please. This just gives you some idea of the relative burden around and the attributable fraction by country. Just to point out the large burden in the country of Pakistan, again, related to unsafe injection practices in healthcare for the most part, with almost 1 out of every 5 persons with hepatitis C in the country of Pakistan, but also direct your attention to the large box that's representing the United States to, again, indicate how the United States is very much a part of this global HCV epidemic. Thank you. Next slide. Let's turn to the United States in a little bit more detail. We do have a strategic plan for hepatitis at the national level with specific targets for elimination of both hepatitis B and hepatitis C. Next slide. Our biggest challenge is HCV incidence. Since about 2011, there's been about a 3-fold increase in new HCV infections fueled by the opioid epidemic over those years, and an increase in injection drug use practices. You can see on the right that much of those new infections were among young persons. Fortunately, as represented in that red line for the persons in their 20s, we are beginning to see some plateauing and some declines in these in the rates of new infections in these populations, but they remain simply too high compared to earlier years. Also, since since these are young persons and women of childbearing age, we have seen increases in mother-to-child transmission, which only increases the importance of screening all adults at least one time for HCV infection as recommended by CDC, and to get people into treatment as early as possible. And for pregnant women, they can make a shared decision-making with their provider about receiving treatment during pregnancy, or certainly to be treated after delivery. Next slide, please. This is a study we did about 10 years ago when I was at CDC, and unfortunately, situation has not changed dramatically, whereby we looked at the where new HCV infections were occurring, represented by the red dots, and where were prevention services for people who inject drugs, represented by the black triangles, just to show, number one, the relatively scarce access to preventive services for people who inject drugs. And when those sites were available, they oftentimes were not where the new infections were occurring. Now, like I say, this situation has improved some, like, for example, in the state of Kentucky, which has done a great job in improving prevention access. But still, we have a long way to go in getting the prevention services properly lined up to match this burden of new HCV infections. Next slide, please. On a more hopeful note, we've had a large decline in HCV-related mortality of over 50% since 2015. Some of this is because of the first testing recommendations, which were directed toward baby boomers, which already had advanced liver disease and could really immediately benefit from treatment. And many of them were already tested and in care. And now we need to extend that testing and treatment services to all persons, particularly for this young population that I'm speaking of. And again, that's why this HERO in practice is so important, because I've shown you this high burden of HCV among people who inject drugs in the U.S. and how they're among young people that we need to immediately find, treat, and cure. Next slide, please. But we have some real work to do. This is a study that I did with other colleagues that was led by Mark Ghani of NIH, where we looked at commercial lab data from 2 large commercial labs here in the United States, where they could look at the trends in testing for HCV antibody, how many of those positive specimens were tested for HCV PCR, and then using an algorithm could estimate how many of those persons were clearing virus indicative of a cure for their HCV infection. And what we estimated that over only about a third of those persons had some evidence indicative of receiving treatment and curing their HCV infection after diagnosing their chronic infection. There have been other studies that have shown a similar trend. And again, this is the kind of gap in diagnosis to treatment that we're seeking to correct with the HERO in practice. Next slide. Next slide, please. Unfortunately, because of this large increase in HCV transmission, there have been, our prevalence has not gone down in the U.S. In fact, the latest estimates indicate that when you take that burden among people who inject drugs into full account, the prevalence of hepatitis C in the U.S. is over 4 million versus the earlier 2.4 million in the earlier estimate. So we're not heading in good directions when it comes to prevalence and incidence in the United States. Next slide, please. So in summary, the national scorecard, we're flashing red on HCV incidence. Fortunately, we have made progress in decreasing mortality and some other trends, as you can see here. But I think the data speaks for themselves as far as the work we need to do for all people at risk to gain access to testing and treatment services. Next slide, please. When we're thinking about testing HCV infection, you start with an HCV antibody test. If positive, you follow that up with a test for viremia, which is often a PCR test. And if that's indicative of current HCV infection. Next slide, please. And you use that testing strategy at the moment because after infection, a certain percentage of persons will clear infection based on their own immune response. And so that test for viremia is required to diagnose current HCV infection. And then over really several decades, persons will have varying courses toward severe liver disease, cirrhosis, and liver cancer. That can be affected by various comorbidities such as excessive alcohol use, HIV infection. But the big point here is the earlier to diagnose and treat, the better, because if the liver disease is too far progressed towards cirrhosis, even with cure of HCV, that person will continue to be at risk because of that liver damage, progressing on to hepatocellular carcinoma. So early testing, early treatment is key. And again, why HERO in practice is so important. Next slide. Fortunately, we have cures, the first cures for chronic viral infections in the history of medicine. We now have available to us to benefit our patients with high rates of cure, as Alan has already shown you, with very convenient, highly acceptable regimens of 1 to several pills a day for 2 to 3 months, a course of treatment. And adherence, high adherence is desired but not required for high viral clearance. Next slide. I think Stacy will get more in detail about this in a moment, but these are the recommended treatments that are available in the United States. And again, 1 to several pills a day for 2 to 3 month regimens. Next slide. This will show you the recommended treatment cascade for persons without evidence of cirrhosis. The testing algorithm I've already shown you. History taking to identify other comorbidities such as excessive alcohol use, various laboratory parameters to identify co-infections with HIV and hepatitis C, evaluate stages of liver disease, and unless there's some indications such as severe liver disease that requires a specialist, treating hepatitis C can be done by primary care providers, providers in drug treatment programs, incarcerated settings, and other parts of the health system because of the simplicity and safety of hepatitis C treatment. Next slide, please. Hepatitis C elimination is a cost-saving program for the United States. Jack Chatwell, myself, and other came together in a model to estimate that cost saving. We can put that reference. We'll send that reference out to you all. That was used by the Congressional Budget Office to support legislation to launch a national hepatitis C elimination program. That legislation, frankly, has not progressed very well in Congress at the moment, but it doesn't mean that a national program would not be worthwhile. It will be, and we need to continue to call for that because there's millions of persons in our country that can benefit from a strong national program. Next slide, please. Please put any questions you have for me in the Q&A function of the chat, or I mean of the Zoom. I think I'll turn it over to my colleague Stacy Truskin, for more exploration of testing and treatment for hepatitis C. Stacy.
Hi, good afternoon or evening, depending on where you are in the country. It's exciting to be with you all and talk a little bit about innovations in testing for hepatitis C. Let me try to advance. There we go. I think we got it. All right. So the goal here is really for simplified testing, and the holy grail here is to move towards a single visit HCV diagnosis and treatment. So really like this test and treat model. The availability of effective HCV treatment has really led to optimism for global HCV elimination. John just shared with us some examples of places around the world that are really doing an extraordinary job of eliminating hepatitis C. So we have the tools. It really is how we can leverage this. For some reason, oh, thanks, Liv, for advancing. Great. Okay. So in terms of community service access, engagement, motivation, along with testing and diagnosis, it really continues to be a major barrier to elimination. But advances in screening have really facilitated reduced visit models of testing, diagnosis, and treatment. I'm going to share a couple of those with you today. We really should be, though, requiring a constant evolution of our existing models of care. As technology advances, so should we. And hopefully by the end of our 20 minutes together, you'll get a sense of what options are available to you and what is on the horizon in the future as you think about what sort of testing and treatment programs you can implement in your sites if you haven't done so already. Different settings and communities will require different types of engagement, motivation, and testing strategies. So all of these tools can be tailored to where you are located and what is most appropriate for the folks you're serving. Next slide, please. So it can be quite a long journey to an HCV diagnosis, and it can take as many as 5 or more visits, depending on the various barriers that a patient may experience. So here's one example of what it can look like. Visit number 1 can be your HCV antibody test, and that can be done through a recommendation of a provider, which then would refer you over to a phlebotomist. Oops. We're a little, there we go. Okay. And then you need to then have that test sent out to a reference laboratory and then come back to receive your antibody test result. But we know that antibody is really just a representation of whether or not you've been exposed to the virus and not necessarily representative of if you have the infection. And for that, you need your RNA testing done. And that often requires another trip to a phlebotomist, sent out to a reference lab, and then coming back to receive your diagnosis. And this is, not even including treatment yet. Perhaps the individual that is giving you the diagnosis may be a treater. Perhaps they'll need to refer you out. And so this can be quite a prolonged process. So you can see here, there's a ton of opportunity to streamline this and implement a simplified testing model and hopefully treatment. With, again, the goal being it happening in one visit. Next slide, please. So the question for you all to ponder as we continue this discussion is, what can we as providers do to scale up our model of care, yet reduce our visits to diagnosis? Next slide. So the first tool in our toolkit is point-of-care antibody testing. These are often also called rapid diagnostic tests to detect HCV antibodies. So again, whether or not you've been exposed to the virus, not if you currently are infected. Most of these tests use a capillary whole blood sample collected using a lancet to prick a finger, and usually only a few drops of blood are needed. It doesn't require a lab technician, a medical professional, or a phlebotomist. Most folks can be trained to do this simple test. If you've ever seen anybody test their finger for blood sugar or glucose testing, it's the same type of technology here, very simple. Results are usually provided pretty quickly, usually in 5 to 20 minutes, depending on the test used. The result usually needs to require the full 20 minutes if it's a negative test result, but if somebody is reactive, it usually starts to demonstrate that second line within about 5 minutes or so. Next slide, please. So there is a point-of-care antibody test available in the US. It's been available for about 16 years. It's called the OraQuick HCV Rapid Antibody Test. It's FDA approved, again, 20 minutes, and it's greater than 98% accurate. If any of you at this point have done a COVID test on yourself or perhaps a pregnancy test, you can see here that 2 lines is indicative of a reactive test or the presence of antibody. 1 line is a positive control, but a negative test line, and it is, of course, invalid if there is no control line present, but very simple to read. Abroad, there are other point-of-care antibody tests approved, including an INSTI test. We have an INSTI option for HIV approved in the United States, but not HCV. There's also the Abbott BioLine HCV test, which is approved abroad as well. Next slide, please. There are lots of examples of how these tests have been implemented successfully. Here's one from abroad. implemented in Paris. It's a rapid HCV antibody test that was done at a single center free testing clinic. And folks in this study were randomized to intervention for testing of HIV, hepatitis B, and hepatitis C. They basically did the point of care test and then referred out to a phlebotomist and then received the diagnosis from the physician. And the phlebotomy was confirmatory testing. And you can see here with the point of care rapid testing, 98% left aware of their status and 90% were linked to care. So really, statistically significant outcomes here that just shows that folks can leave that first encounter with knowledge of their status. Next slide, please. Here's another example of a best practice model in Pretoria, South Africa. People who inject drugs in South Africa carry a high burden of HIV and hepatitis C with co-infection rising. And so the study methods here were community-based, decentralized point of service model with a point of care screening for HIV, Hep C, and Hep B with on-site PCR confirmation. And they provided integrative antiretroviral treatment, PrEP, Hep B vaccination, and also direct acting agent therapy. And the results here were about an N of 213 recruited with a relatively high seroprevalence of anti-HCV at 82%, 70% were HIV positive with 57% co-infected. And out of this cohort, 95% initiated hepatitis C therapy with 86% achieving a cure, and very high rates of initiating antiretroviral therapy at 92% with great viral suppression at 81%. So again, that one-stop shop model of being able to test and link somebody to treatment, very effective here. Next slide. We can also integrate on-site testing with other innovations. So this example here is leveraging the point of care anti-HCV antibody test. Then if that's reactive, drawing blood, and then sending that confirmatory RNA test out to a reference lab and getting your diagnosis at visit 2. Another example here is just doing on-site phlebotomy and ordering an anti-HCV antibody test that reflexes to HCV RNA, all within that reference lab. So the result is you also get a full picture of somebody's status, whether or not they have current infection, at that second visit. And so both of these two options really shorten the time to diagnosis. They're just done slightly differently. Next slide, please. Another type of testing option is something called dried blood spot testing, shortened to DBS. Often, DBS testing involves, again, a finger stick, capillary blood samples, and you put that sample on filter paper, which is dried before it's sent out to a reference lab. The nice thing about dried blood spot testing is it can be used to test for other infectious diseases like HIV, hepatitis B. So you're getting all the information that you'd really want before you'd start to initiate treatment for somebody with that hepatitis B status. And anybody can collect a dried blood spot sample if they're properly trained with the Lancet and how to complete that the sample on filter paper. Next slide. So this is what a successful sample looks like on filter paper. You can see the top here are the satisfactory specimens really taking up a full spot on the filter paper. Unsatisfactory specimens are either usually too little or not one big spot of blood happening in two or three discrete areas. And so it's simple to do this. Usually you let this dry before you would send it out. Next slide. We'll walk us through a little bit more of the details here. So finger prick, you go ahead and fill out that filter paper sample. It gets shipped away in a biohazard specimen bag and into an envelope, and then it gets delivered to the lab. As I mentioned, you want it to dry, usually for 1 to 3 hours before you package it up. And it's stable at room temperature for up to 30 days. So it's a nice way to get a test result. And usually you get the results back once it reaches the lab in a matter of a few days. Next slide, please. So here's a great example of a program that's done a wonderful job of implementing dried blood spot testing. This is Central City Concern out of Portland. They serve a population that experiences homelessness, and all new clients at their homeless healthcare centers, medically supported detox centers, and partner opioid treatment service and street medicine initiatives are all offered DBS testing. HIV and Hep B testing are also tested on that same card. And hepatitis C coordinators contact clients to schedule treatment initiation once those test results are back. And you can see here that among those that were HCV RNA positive, which was a little over 1,400, almost all of them started treatment, 1,360 patients with excellent outcomes. And so again, this is a way to get a full view of somebody's infectious disease status within one set of tests. The other nice thing here too is it doesn't require accessing veins. So if somebody is actively using drugs and they don't have great venous access, it's a nice way to be able to get the blood that you need without re-traumatizing the vein or having to search for something that might be hard to find. Next slide, please. So what would it look like to move to single visit testing, diagnosis, and treatment? And the goal here is really to be able to get that confirmatory test, that RNA test at that first visit if needed. And so what a single visit could look like is in a low hepatitis C prevalence setting. So in a primary care center like mine, it makes sense to do an antibody screen first. And I could use a point of care test here, and we might in our sexual health clinic. And then if that's reactive, being able to implement a reflexive RNA point of care test. The other option is that if you're working in a high HCV prevalence setting where there's been a lot of exposure to hepatitis C, the seroprevalence has already been documented as being elevated, it may make sense to just go right to an HCV RNA point of care test and do that as your first step. Next slide, please. So what does RNA testing, that's point of care, look like in the United States? So point of care RNA tests can use multiple sample types, including serum, plasma, venous whole blood, capillary whole blood, and oral fluid, and it can often test for a variety of illnesses. Last June, almost 2 years ago to the day, actually, the FDA approved Cepheid's Gene Expert test and a Gene Expert Express system as the first HCV RNA point of care test in the US. And this system can be used in CLIA wave settings to detect RNA from finger stick blood within 1 hour. And it provides positive results in as little as 41 minutes with negative results requiring the full 60-minute run. Basically, finger stick whole blood is taken from a finger prick and collected in a little microtainer, and then that blood is dispensed into the cartridge and loaded into the Gene Expert system. And you can see a picture of what it looks like in reality. Next slide. So I mentioned the term CLIA waiver. So just a quick note about what that is and what they mean. So a CLIA stands for Clinical Laboratory Improvement Amendments, and a waiver simply applies to very simple, basic laboratory tests that carry a low risk for error, and these tests are known as waive tests. And there are a couple of different classifications of test categories by federal regulations. One is waived, one is moderate complexity, and then high complexity. And CLIA waivers only apply to waived tests. Again, the very simple ones that most of us are familiar with from either doing in a home setting or very, very simple, like blood glucose testing, a rapid strep test, flu test, COVID-19 test, pregnancy test, very basic with little room for operator error. The requirements for CLIA waive tests require a certificate of waiver, and that's a CMS form 116 in the US. These require minimal oversights with no routine inspections, although staff does require basic training and some quality management is required, particularly if there are controls involved to test the veracity of the test. So you want to make sure that you have that in place. And CLIA waivers allow us to do testing in non-traditional settings like mobile units, schools, field sites, like out in community, and also in correctional settings that don't have large clinics or labs. Next slide, please. So if you're thinking, what do I need to get a point of care program running? There are a couple of things that you should think about considering. One is site selection criteria, governance, and community engagement. If you're working for a community-based organization, you should have policies and guidelines in place for how you're going to do this testing and what your quality control measures are around risk and quality management. There should be training and protocols as well to make sure that everybody is trained to proficiency on these tests. Connectivity and reporting systems, particularly if you're testing for reportable diseases like HIV and in some jurisdictions, hepatitis C, hepatitis B. And then you need to consider to your supply and management costs, how you continue to have things stocked, and if you can continue to afford them. Next slide, please. So giving another example about a global best practice model, the National Australian Hepatitis C point of care testing deployed this point of care RNA technology. 103 sites opened across all states and territories, including prisons. There were 20 high-intensity testing campaigns at 14 prisons. There were 368 operators received that point-of-care testing training, and overall over 33,000 HCV point-of-care tests were done. And about 3,600 people with current HCV were identified. And of those individuals, almost 1,900 people were treated, which is extraordinary. And this endeavor really accomplished quite a bit. It accounts for about 10% of all HCV treatment in Australia was driven by this point of care testing model. Next slide, please. So when we think about moving to a single visit, thinking about the strategy that is most appropriate for our setting, is it the single visit where you're doing a point of care HCV antibody test with a reflexive point of care HCV RNA in a low prevalence setting, or are we thinking more about a high hepatitis C prevalence setting and going straight to the RNA? And there are a couple of things to consider when we're pondering this question. Next slide. So the first is cost effectiveness of testing, and we're going to talk a little bit more about that. The prevalence of HCV infection is also important, and we touched on that in the last slide, that if prevalence is low, starting with the lower cost antibody test is probably prudent, as opposed to where a lot of folks have exposure, there's a high antibody prevalence, maybe individuals have been treated in the past as well. And so getting right to that RNA test result is really important, because the antibody test is not going to give you the information that you need. Timeliness of the delivery of results is really important. If you think about something like perhaps a syringe service programs where folks are really in and out, waiting 60 minutes for a point of care RNA test may not be the right fit for that particular model. But if someone is coming into a drop-in center where there are other services and they're going to be there for 60 minutes, that might be a good fit. So thinking about what is the tolerance for someone to hang out for a period of time. The opportunity for linkage to care is also really important, as well as the capacity to perform point of care testing and provide the necessary counseling. Access to a point of care RNA testing platform or program is really key here. Do you have access, or will your organization obtain access to a Cepheid machine? Is that financially sustainable for the organization as well? Available resources and capacity to support point of care HCV RNA testing. Do you have the staffing model? Do you have space? All of that are considerations as well. And then requirement for mobility. If you're out on a mobile clinic, or if you're just setting up a table somewhere at a health fair or an event, it may not be prudent to bring an RNA point of care testing module with you. Next slide. Okay, so point of care antibody testing really should be a path to facilitating scale up. And when we think about the financial implications of this, point of care antibody testing can be less expensive than RNA testing. In terms of US dollars, it's about $7 per test for point of care antibody testing, but $40 for RNA testing. And point of care testing, antibody testing is lower complexity test. It's a little easier to train. There's also improved acceptability of point of care antibody testing among patients and providers because of that long RNA runtime. So if folks are looking to just move through and get some information and move on to the next thing, 20 minutes is about what folks are going to be able to tolerate. And then improved efficiency of the platform is needed for the RNA point of care testing model. Right now, it limits 4 tests per hour. 1 per module for a 4-module machine. And you can use the HCV antibody testing to triage patient samples for high-intensity testing campaigns. So thinking of the antibody test as a place to jump off is helpful. Next slide. All right, so thinking about the right test for the right patient in the right setting is really key here. So if we center the patient again and we think about, has this patient ever been told that they have hepatitis C? If the answer is yes, then they likely have HCV antibody already present. And so repeating that test may be a waste of everybody's money and time. So jumping right to that RNA test is going to be the next way to go. You can either do that through a laboratory RNA test or a dried blood spot RNA testing versus that point of care RNA test. So you have 3 options for you for those patients. If somebody has never been told that they have hepatitis C, the next step is to find out, have you in fact been exposed? Let's do an HCV antibody test. If the antibody test is going to be a point of care test, you have a couple of options. There is the dried blood spot RNA test, the point of care RNA test if it's reactive, and then you could also send out to the laboratory RNA test. If you end up doing a laboratory antibody test, the goal really is to do a reflexive RNA test. That is the standard of care. So you get one answer with 1 blood draw. Next slide. So a little bit about future diagnostics in the pipeline, just to finish up with this. There are a couple of emerging technologies that are worth mentioning. There's the DASH PCR platform. There's nucleic acid platforms that are coming out, and also smaller footprint analyzers that require minimal laboratory infrastructure. There's also rapid antigen testing. So HCV core antigen assays continue to evolve as a lower cost alternative to PCR-based RNA testing. There's also multiplex and integrated testing platforms that combine HCV with other infectious disease testing. And then there's also this big question around like future of at-home RNA, future of at-home HCV testing. And I also just want to mention that there's been a lot of conversation about hepatitis B point of care diagnostics in the United States as well. I think many of us that are thinking about implementing a test and treat model, we often want to know, particularly for our at-risk patients, could you be infected with hepatitis B as well? And so if we have good contact information for our patients, sending a test out and getting that information back may not preclude the initiation of treatment, but boy, wouldn't it be handy to have a point of care hepatitis B test as well so that we could understand somebody's status. And so there's a lot of interest in technology being developed in that area too. So more to come. That's it for me.
Thanks so much, Stacey, for that presentation. Everybody who's putting questions in the chat, fantastic. Please keep them coming. We're going to have some time at the end of the session for questions. I would now like to pass to Jocelyn James and Russell Sandvold, who are going to talk to us a little bit about care navigation. We've heard a lot about testing and treatment, and we're going to be moving on now to some of the interventions for patient-led interventions. So I'm going to grant screen control, and if Jocelyn and Russell feel free to jump in whenever you're ready.
Okay. Can you hear me all right? Wonderful. Okay. So my name is Russ Sandvold. I am the Care Coordination Program Lead at Hepatitis Education Project in Seattle. And I'm co-presenting today with Dr. Jocelyn James. And yeah, just give a moment to Dr. James to introduce herself.
Oh, sure. Yeah. I'm Jocelyn James from University of Washington in Seattle, and I get to work with Russell at Hepatitis Education Project and on some other local hepatitis C work.
Thanks. Yeah, so we are just going to be talking a bit today about hepatitis C care navigation. So we can move on to the next slide.
You should be able to move them at your leisure. If you can't, let me know and I'll progress for you.
I see. Okay, thank you. Care navigation can be an important tool in addressing the various barriers that patients face when accessing Hep C treatment, and in deciding whether to initiate treatment. So navigators can help screen patients for interest in Hep C testing and provide encouragement to complete testing and initiate treatment. And they can initiate linkage to care with appropriate and convenient treating providers, provide support and encouragement throughout the treatment process and education on infection risks, and can also ensure that patients are connected to a PCP or continuing care for co-occurring health issues and offer periodic reinfection screening. All right. So with the relative ease and like extremely high cure rates that DAAs offer, often the most common barriers that patients that we see face in accessing and successfully completing Hep C treatment have to do more so with competing priorities and lack of access to essential needs and technology. So we've heard many times from patients who've attempted to initiate Hep C treatment in the past that they'd become disengaged prior to initiating meds just because they had a lot of appointments and ended up missing some of them and basically just fell off somewhere along the way. We've also heard from patients that they've experienced discrimination and stigma in traditional healthcare settings, and that in some cases they were asked to stop using to be eligible to access treatment. Another barrier that we often see is a lack of reliable access to phones, email, and other technology to schedule and stay on top of follow-up appointments and communicate with their care teams. And many patients initiating treatment are also experiencing homelessness or housing instability and are struggling just to meet their basic needs. So Hep C treatment just might not feel like at the top of their priority list for them. And effective care navigation models can help patients overcome most of these barriers by just connecting them with a low barrier treatment provider and providing wraparound services to help meet some of those essential needs and consistent follow-up throughout treatment to help them stay on top of their treatment. So in a study following patients enrolled in Inspire's Hep C care coordination program in New York, and a matched cohort of patients enrolled in treatment without care navigation. The study found that 72% of patients enrolled in care navigation initiated Hep C treatment, compared with 36% in the matched cohort. And it also found that 65% of patients who were enrolled in care coordination and initiated treatment were cured, while 47% of those in the matched cohort who initiated treatment were cured. So definitely seeing some benefits to patients enrolled in care coordination just in like progressing them through the continuum of care there. And care navigators can build an organization's capacity for screening, staging, and linking patients to care. Um, and in workplaces where providers and clinical staff are stretched thin, navigators trained in phlebotomy can take on a lot of the responsibilities of getting someone diagnosed. So that could be testing, providing hepatitis C lab results, completing those staging lab blood draws, and linking patients to an appropriate treating provider. And this model can be successful in a variety of settings, including community-based organizations where clients are accessing syringe service and where the staff tend to have a strong rapport with their clientele. And in hospitals or specialist settings, navigators can be utilized to coordinate referrals and follow-up appointments and can be trained in coordinating diagnostics and prescriptions and can engage with patients who receive Hep C positive tests while they're in the ER. In jails and in jails and prisons, navigators can conduct Hep C screenings and link patients to providers while incarcerated or upon their release to ensure continuity of care. And offering telehealth can be a valuable option for patients with limited mobility who are in more remote areas or who just lack reliable transportation methods. And in indigenous-led and culturally responsive models, trusted community members and leaders can build care navigation and treatment models that include culturally safe approaches to help engage with community members and build trust with them. So HEP's Care Coordination Program has been serving patients in the Seattle area for around 10 years. And this slide highlights just some of the successful strategies that we've implemented and kept around. Implanting care coordinators in locations with high prevalences of people who use drugs has ensured that we're engaging with individuals who are vulnerable to Hep C infection. And for us, this means having at least one care coordinator on site during our open SSP hours and another care coordinator who meets clients more so out in the field at community outreach sites, supportive housing buildings, things like that. Placing care coordinators at sites where people who use drugs frequent or receive services, such as MOUD clinics and SSPs, also helps care navigators build rapport with clients who might be hesitant to initiate treatment. And arguably the most effective component that we've been able to utilize is pairing our care coordination with low barrier and flexible treatment models. So we found that when pairing our model with a pharmacy-based treatment model that offers a lot of flexibility, that we've been able to help clients overcome a lot of the barriers that we've discussed earlier. Partnering with a pharmacy that offers medication delivery to clients, residences, or sites where they access services is also crucial, just with helping clients with mobility issues access their medication and ensuring that they receive their meds on time and avoid large treatment gaps. And offering medication storage is also very helpful for anyone who is living unhoused, might not have a safe place to store meds, and might cite that as an issue in starting treatment. Incentives has also been extremely helpful, such as grocery store gift cards, which is what we offer. And we offer that for testing and accomplishing benchmarks throughout their treatment process. And this has proven really helpful just in like keeping clients engaged throughout the treatment process. And it also helps just ensure that they have access to more of their essential needs, like food throughout treatment. So that also helps with avoiding some of the reported stomach upset issues from DEAs when it's taken without food. And lastly, consistent check-ins with patients to provide appointment reminders, adherence check-ins, and encouragement throughout treatment, whether that's by phone, email, whatever way we can reach them or through a designated alternate contact has gone a long way just with building trust with clients and helping them stay on top of their treatment throughout their treatment process. And I'll pass to Jocelyn.
All right. Thanks so much, Russ. So now I'd like to talk about a specific model of care navigation, peer support. And peers, of course, peer support specialists or peers can really provide an important complement to the patient's team and to the process for moving people through that hepatitis C care cascade. The general idea here is that peers are people who have direct, lived, or living experience with similar conditions as the client, and that they can bring knowledge from those experiences that's unique and helpful. Of course, peers can provide a variety of roles, and there's no one-size-fits-all approach to peer support. There are a number of examples of how they're utilized. Some of those examples include peers running support groups, which could be virtual or in person, peers doing one-on-one support or mentorship for people with a similar experience. They can help with networking. And one important point that's not on here too is peers can be really important voices, advocates, understand probably from a different perspective some of the barriers that people go through as they're trying to get through the hepatitis C treatment process. And so they really can use their voices in their advocacy in important ways. Sorry, there's a little lag there. Okay. So why are peer support models effective? Peers can help to address the stigma and mistrust that many have experienced. They can help to educate and increase health literacy. They can be really important for supporting treatment adherence and really for helping people to navigate when the systems they run into are kind of complicated and it's really easy to get discouraged and turned away from that. Peers can be a hand to hold to help people get through that and understand it, not give up on their treatment. Peers can be particularly effective among certain populations. So people who use drugs, especially if peers themselves have that lived experience, people who are experiencing homelessness, justice-involved populations. And then I'll show a model, a really best practice model for utilizing peers in rural communities. And there's evidence supporting peer as peer models, as well as these other patient navigation interventions, and some evidence that peers increase screening as well as linkage to care and initiation and completion of treatment. Okay, this is one example that I mentioned just a moment ago. This is from Oregon. And in rural Oregon, rates of hepatitis C treatment uptake have been really low among people who inject drugs. And so this was an initiative to roll out peer-assisted telemedicine for hepatitis C treatment in rural communities among people who use drugs. And it was actually a randomized control trial in which peers were involved in both arms. They were involved in the telemedicine arm. They were also involved in the other arm, which was really kind of a referral to local providers. However, the level of involvement was different. And the peers in the model that involved telemedicine were doing things like delivering medications, bringing a laptop to somebody at an encampment to help them connect with the provider. So it was really a more intensive peer model. That being said, the other really important distinction there is that one was a low barrier treatment model, which was paired with the peer support. So I think similar to what Russ was talking about regarding patient navigation and his experience, the best effect coming from patient navigators working in collaboration with really low barrier models of care delivery. I'd say this supports that general idea too. And as you can see, the numbers in terms of the percentage connected to a treatment or initiating treatment within 3 months, and also the numbers who achieved SVR12 were radically different in the two groups, favoring the peer-assisted telemedicine model. I won't spend a lot of time on this one. This is another example looking at peer support. I think one thing that's important here is these researchers compared a really enhanced usual care to that model, plus a financial incentive, as well as that enhanced usual care to peer support. And peer support appeared to maybe outperform the usual care. However, it wasn't statistically significant when you looked at rates of treatment initiation. However, that usual care model was a nurse-led model. that provided a lot of support. It was a multidisciplinary team. So that usual care was really, again, enhanced and robust in and of itself. And there did appear to be some additional benefit from utilizing peers. As far as SVR rates, the outcomes were essentially equivalent. Okay, and then in England, this study looked at analysis of a huge amount of data from the English National Health Service registry, so over 30,000 patients, and compared patients who were managed in networks that involved peers with those who were managed in networks without peers, and looked at a number of outcomes. And what they found was that for two outcomes in particular, initiating treatment and then also completing treatment, that it did appear that people in networks with peers were more likely to succeed to achieve those outcomes. So thankfully, there are a lot of opportunities to really enhance hepatitis C treatment, including utilizing peers and patient navigation in general. We have increasing access to digital navigation for people who can access those services, or when we can get devices to people. There is a real opportunity to expand the peer workforce. Of course, there are some challenges that come with that, compensating people adequately, training, defining what peers will do, retaining, supporting them. There can be high rates of burnout. So there are challenges that come with that, but also helpful models of doing that successfully. And then there are opportunities to decentralize hepatitis C care using pharmacy-based models like what Russell was mentioning, other ways of getting treatment out to meet people where they are, community prescribing, mobile health and outreach, and ideally with those interventions also combining the hepatitis C treatment with other really important and related services. There are some ongoing challenges. I mentioned, challenges around funding for peers and the challenge of burnout. It can be hard, of course, to treat the most marginalized populations. And then as more interventions are rolled out, the challenge too of just kind of coordinating between these and ensuring continuity of care across systems. And I think that is the last slide. So if you have questions, please put them in the chat and I'll pass it off.
Thanks so much, Jocelyn and Russ. We'll have the opportunity when we move into the breakout rooms after the break to talk more about care navigation strategies and peer support strategies. But for our final presentation for this session, I'd now like to pass to Dr. Sean Folade-Nulia, who's going to talk to us a little bit about sort of what works and why and in what conditions. So I'll grant you screen control, Sean, and let you advance at your leisure.
Thank you so much, Liv. It's so exciting to be here.
Tell me when you're ready.
Can you hear me?
Loud and clear.
Perfect. Okay. Excited to be here with you all and embarking on this journey to eliminate hepatitis C in your settings. I'm going to preface my talk by sharing that I'm going to be talking about principles of implementation science broadly because we are going to be using an implementation science approach to support our implementation. And the reason we are doing that is because we want to work together to build programs that work for the patients at your settings, that work for staff at your settings, so that those programs can be sustainable. Live. Okay. Live, my slides aren't moving. Okay.
Can you progress?
I just need to... Okay. Those are my disclosures. Okay. So we all on this call are here because we care about people. In particular, when we think about people with substance use, we cannot think about hepatitis C in isolation. The chart shows overdose rates in the US, probably one of the biggest public health challenges of our time in the US, with over hundreds of thousands of people dying unnecessarily. This overdose epidemic, like you've already heard, also drives hepatitis C. And so that as we think about providing care for people who use drugs, we all recognize that it's in the context of overlapping epidemics, substance use, hepatitis C, overdose, stigma, unstable housing, and limited access to trusted care. We all just heard about how effective Hep C therapy is. It's amazing. We can cure essentially everybody that has access to these therapies. I'm going to provide the evidence for treatment for opioid use disorder. So the first plot shows a study where people got different treatments. The top bar are people who got no treatment. The second to the bottom bar, people who got buprenorphine, and the last bar, people who got methadone. And the message is that when patients are treated for opioid use disorder, it reduces their substance use. The next plot is from a systematic review looking at the impact of either buprenorphine or methadone on hepatitis C treatment, on hepatitis C infection acquisition. And we see clearly that patients that are on MOUD are less likely to get infected with hepatitis C. In fact, this data suggests that patients who are on MOUD have 50, sorry, my apologies, have, I am not sure what's going on here. My apologies. The first plot is a diagram showing the impact of MOUD on HIV transmission, and we see that people who are on MOUD have a significant reduction in acquisition of HIV. Trying to pull all this together, the big picture is that we have evidence-based interventions. And by evidence-based, I mean that we have interventions that are shown to be effective in addressing multiple conditions that people who use drugs have. Opioid use disorder, we have buprenorphine or methadone and extended release naltrexone. Other substance use disorder, we have contingency management. Hepatitis C, we have oral DAAs. HIV, we have HIV PrEP and HIV treatment. And I bring this range of conditions up because we have multiple people from different contexts, and you already are providing services for some of these conditions. However, majority of people who use drugs do not have access to these services. And in particular, as we think about hepatitis C treatment, we've already heard about how the siloed US healthcare system makes it difficult for people to access services. In many settings, providers are uncomfortable with varying aspects. For the rest of this talk, I'm going to be talking about substance use disorder care integration into an HIV care setting. And across all these conditions, patient-level barriers include stigma, distrust, competing priorities, and lack of support that people usually require to engage in care. And so when we think about implementation science, there's a lot of buzz about that term. What exactly is implementation science? It's really just an approach to systematically increase uptake of these evidence-based interventions among the people that need them the most. The clinical trials are done in perfect patients. None of us in the real world are perfect. So how do we get these evidence-based interventions to our patients? To do this, we have to understand why they are not getting this evidence-based intervention. Some of the reasons, like I shared, are things at the level of the patient. And honestly, a lot of the reasons are things at the level of the setting, the context, the clinic, where we provide care. So the first thing that implementation science asks us to do is to identify contextual determinants. And that is just fancy speak for what are the barriers and facilitators to people having access to these evidence-based interventions. Because if we truly understand what the barriers are, then it can guide our implementation process and how we translate knowledge of effectiveness of these interventions to making sure that they are available to the patients that need them the most. It's very critical that the people that know the most about these barriers and facilitators are involved in choosing the best strategies to overcome the barriers and enhance the facilitators, which is why for Hero in Practice, it really is going to be the clinician champions, the patient navigators in the clinic, the system leadership that is in partnership telling us what they think will be the best strategies for integrating hepatitis C treatment into your setting, because having you tell us what you think will be best will actually lead to choosing strategies that have the highest likelihood of optimal implementation outcomes. So by implementation outcomes, what exactly am I talking about? I'm talking about strategies that are acceptable both to the patients and the staff in your setting, because if they're acceptable, they're more likely to be adopted. Strategies that are cost effective, because if things are expensive, they can't be sustained. They have to be feasible. They have to be things that can be implemented with fidelity, and they have to be sustainable. I'm going to use an example of a different evidence-based intervention. And the reason I'm using a different evidence-based intervention is because that has already been done. We already have a blueprint. We know that it works. And my hope is that at the end of this talk, you will, one, understand why we're using an implementation science framework to support implementation of hearing practice, and also participate in our use of this implementation science framework. There are multiple implementation science frameworks, but for this specific project, which we implemented in our HIV clinic in Baltimore, we used the Chamberlain stages of implementation completion. And this project came about because we have a large HIV and infectious disease clinic where many of our patients were coming in because they had substance use disorders. We did an amazing job of treating their HIV, but we really were not doing as well with treating their substance use disorders. And so this project that I'm going to talk about is about integrating opioid use disorder treatment into the HIV care setting. And at the back of your mind, I want you to think about how some of the things that I'm talking about might apply to integrating hepatitis C treatment into your setting. For this project, we use Chamberlain stages of implementation completion, which divides implementation into 3 stages: pre-implementation, an implementation phase, and then a competency phase, which is a sustainment phase. For hearing practice, we also have a pre-implementation phase, an implementation phase during which there will be intensive implementation facilitation, where you will receive support to implement the strategies that you think will work best in your setting, and then a phase where we're really looking to support sustainment of what you have implemented. So for this project where we were trying to integrate opioid use disorder treatment into an HIV care setting, during pre-implementation, there was engagement. That essentially were meetings with clinic leadership, clinicians, other staff to assess the need, and also to identify how we would fund the program we wanted to implement. The need assessment was really focused on assessing barriers and facilitators, and that led to development of a model which had potential to be feasible in their setting. And then we did readiness planning, during which we cataloged the resources that were in the clinic, the existing workflows, so that the approach to implementing opioid use disorder treatment leveraged what was already existing and was a good fit for the workflow. So for many of you on the call, you already have gotten surveys where we're trying to assess what your thoughts are about the need for implementing hepatitis C treatment in your setting, the current resources in your setting, the current workflow. And we're really interested in your feedback because that helps us to support you to develop the strategies that would be the best fit for your setting. Here is how we use the assessment of barriers and facilitators. The surveys we had pre-implementation told us that most providers in the setting did not feel comfortable providing treatment for substance use disorders. Most providers in the setting wanted additional support to be able to provide treatment for substance use disorders, and they also needed more time to be able to do this. So that as we picked the implementation strategies together, it was important to address the barriers of limited comfort and lack of support for substance use disorder care noted in the needs assessment. And so what is an implementation strategy? It essentially is an action that is decided upon to increase adoption, implementation, and sustainability of an evidence-based intervention. And for this example I'm giving you, the evidence-based intervention was buprenorphine for opioid use disorder treatment. There are 73 implementation strategies that have been decided upon by the experts in implementation science as being effective in increasing uptake of evidence-based intervention. And so our job is to decide, based on our context, which is the implementation strategy that will work the best. And so for this project, implementation staffing was required. And so staffing for this project, which is actually very similar to the Hero in Practice, is a clinician champion. And in this project, it was an experienced HIV clinician who supported substance use disorder care integration into the HIV care setting. The champion in Hero in Practice will support hepatitis C treatment integration into your specific clinical setting. This project had peer recovery specialists who were community members with lived experience of substance use, who were partners in implementing the project. Hero in Practice does not require people with lived experience, but does require patient navigation to support patients through the process. There was a need for other supports, and so there was an addiction psychiatrist and a therapist who were integrated, who reviewed cases with the team to support them as they developed expertise in providing substance use disorder care. And because we recognize that beyond the clinic, patients who require supports, efforts were made to identify supports in the community beyond the clinic, where if patients needed higher levels of substance use disorder care, they could be linked to care in those settings. These were the implementation strategies used in Hero in Practice. So we had training and ongoing consultation. For each strategy, it is critical that we define it so everybody is on the same page. So the definition was an on-site ex-waiver training, which was required for buprenorphine waiver prescription at the time, and then discussions at the HIV provider conference, which was training. That happened once for the ex-waiver training, and then the HIV substance use disorder training happened quarterly. Local technical assistance that was provided by the clinician champion, who supported providers and other staff across the clinic to understand the approach to integrating opioid use disorder treatment into their care, and that was continuous. Patient engagement was provided by the peer recovery specialist. In Hero in Practice, patient engagement will be provided by the patient navigator, and that occurred weekly. And then there was monitoring, where every week there was an assessment of progress, what was going well, what wasn't going well, so that we could figure out an approach to overcome the barriers. For Hero in Practice, there's a red cap registry that will be used to assess and monitor. In the implementation phase, there was fidelity monitoring. There was service provision started in January of 2019. Prior to providing services, it was important that everybody was aware. So we advertised at clinic meetings. Any member of the clinic could refer patients to services. And we reviewed logs and process lists at weekly implementation team meetings to make sure that we were on track. In evaluating whether what is implemented works or not, beyond effectiveness, there are a couple of implementation outcomes that are important to understand. Reach. Are we reaching a broad, representative population of people that should reach this, that should be benefiting from these services? Adoption. What proportion of providers and staff are referring patients or providing treatment? Implementation. Are we implementing the project the way we said we would implement it? And maintenance. Can the project be sustained beyond the period of active implementation facilitation? And so real quick, for this project in the clinic, 258 patients were referred, 71% engaged in substance use disorder care. And amongst those that provided consent for their data to be used in research, when I look at the gender, race, educational distribution of patients that received services, they were very consistent with the population of patients in the clinic. With regards to adoption, we went from 3 providers who had either prescribed buprenorphine to 29 providers who had prescribed buprenorphine. 75% of providers referred patients to the program, and there were over 4,500 peer contacts, suggesting high adoption of the program. With regards to effectiveness, we see that the program, if you look at people at baseline compared to 6 months, they had significant reductions in anxiety, significant reductions in ED visits, significant reductions in hospitalizations, increases in viral load suppression, increases in proportion care of their hepatitis C, and reduction in substance use. Again, kind of alluding to some of the data that was presented, that hepatitis C treatment or treatment of any of these conditions that impact people who have substance use disorders might have downstream impacts on other conditions we're not treating directly. The program was highly acceptable to staff. With regards to implementation, there were some continued gaps where staff still say that they would require more time to be able to do this effectively, which is why it's important to continue to monitor implementation, because the fact that we think something will work doesn't mean it will work. We need to make sure that we catch the barriers and address them in real time. From the perspective of patients, patients found the intervention to be appropriate. They found it to be acceptable. And when you think about the things that were most appropriate, they liked the fact that it was one-stop care. Hero in Practice will be one-stop for our patients. They liked the fact that there was no judgment. They liked the care coordination continuity, which is a big part of what the patient advocator will be doing in Hero Practice. And they liked the fact that they had choice. It was also perceived to be effective. And when we think about effectiveness, it's not just about care. And patients thought that participation in the program helped them regain stability, function, and confidence. It wasn't all about getting medications. And I think probably the most important part of this program, which is why I decided to show you this example, this is data that was recently run by Maria Latimer, who is on this call, and Dustin Key, who is a resident at Hopkins. And what you see is that it looks at the number of MOUD prescriptions. In the pre-implementation phase, you see that MOUD prescriptions were very low. With implementation, the number of people receiving MOUD prescriptions went up. But I think even most exciting is that after active implementation facilitation, not only the number of MOUD prescriptions sustained, it actually went up. And so the goal and the hope is that if we can use a systematic implementation science-informed approach to implementing integration of Hero in Practice into your settings, we can implement in a way that is acceptable, appropriate, and feasible, which then translates to sustainability of these programs in your settings. So in conclusion, it is so important that we understand the barriers and facilitators in your individual settings. Please do the pre-implementation survey so we have that information. And together we're going to pick strategies that will lead to acceptable, feasible, and sustainable programs in each setting. Thank you. Liv, you can stop sharing. Thank you, everyone. This is my long list of people I need to thank, including all of you that have listened to this talk just prior to the break.
Thanks so much, Sean, for tying that all together so nicely, all of the interventions that we've heard about in the first session. I can see in the chat that we've already had some of the questions answered. There will be a lot of time for discussion in the second and final session that we have after the break. And it's been a long sort of hour and a half of a lot of amazing information to digest. So I'll break us now for 10 minutes, give you all a chance to get a coffee, get a snack. And then when we come back, we'll be moving into 3 different breakout rooms where we'll be hearing more from our incredible care navigators that are going to talk to us a little bit about their programs, some of the challenges that they experience, and some of the facilitators to care navigation. So I'll see you all in 10 minutes for the final session. Thanks, everybody, and thank you to our amazing presenters for this first session. Alrighty, we'll just give folks another minute or two to come back. Hope everyone has a coffee, although it's the afternoon. I guess for most of you, still warranted. I'm on to my second. Hope you're all joining me. You can see a few people have joined. Welcome back. Fantastic. Alrighty. So welcome back, everybody. Thank you so much for joining for the first session where we heard all about some incredible interventions that have been demonstrated to enhance the hepatitis C care cascade, everything from testing interventions through to peer support, care navigation, and really tying it all together is that implementation science framework. And what we've got the opportunity to do now is to break out into some smaller groups and really get into the nuts and bolts of some of these care navigation models. We are going to be moving out into 3 separate rooms. Each room is going to be facilitated by an incredible care navigator, and they'll introduce themselves to you properly in the rooms. But we have Katie Kitzmiller, we have Bria, and if you put your hands up if you're here back in the room. Yeah, fantastic. Hi, Katie. We have Brianna Brophy who's joining us as well as Wes Wampler. And then Morgan, if she's back on the line as well. There's so many people in the chat, but Morgan will be joining us. Morgan, there you are. Hi, Morgan. To basically share an overview of their care navigation model and some of the best practices that they employ, some strategies and some barriers that they've faced. And then there'll be an opportunity for you to ask them any questions. We'll have a bit of a discussion around sharing shared experiences and challenges, discussing really practical solutions, and the opportunity to basically learn from each other and learn from different service settings. In terms of some discussion questions, after you've heard from our amazing care navigators, we would love to learn more from you. You're on the ground. You are at the sites delivering services, and we want to know what key challenges that you face in delivering Hep C testing and treatment services. What barriers do both yourselves as service providers, but also patients experience progressing through that care cascade? What strategies have you used and have found to be effective in improving engagement in care? How are the peer support workers or the care navigators integrated? What's worked well? What is still quite challenging? And what partnerships or collaborations have helped you really strengthen your program? And then finally, any practical changes that could improve Hep C care delivery in your setting. These are all up on the screen, just guiding questions to sort of help stimulate some discussion in your groups. After about 30 minutes, just under 30 minutes, we'll come back into this main room and share some of the learnings from your group. So without further ado, we will break you out into your 3 breakout groups now, and you'll have a chance to hear from some of our amazing Care Navigator facilitators. Thanks so much. Bye if you are able to launch whenever you're ready. Hi, Russ. Welcome back. Everyone should be filtering in the next minute or so. Hi, everyone. Welcome back. Alrighty, I think pretty much everyone has filtered back in. Thank you so much for participating in the breakout room session. I hope you got some value out of being able to ask our incredible facilitators some questions. Just before we wrap, maybe 1 or 2 key points from your breakout room that you'd like to share with the wider group. Maybe we'll start with group 1, which I think might have been Brianna. Maybe just one key point that you'd like to share with the other rooms that you didn't get a chance to listen in on your discussion.
We talked about, I mean, with different states, different testing, different insurance requirements, like South Carolina is not a Medicaid expanded state. So we don't have a lot of patients that are Medicaid. Most of our patients are uninsured or underinsured. So really working with, Epclusa and Mavyret to work on those financial assistance programs to get medications covered for them. Otherwise, having to jump through all the hoops with the insurance barriers for all the additional labs that are needed for the patients that do have insurance. So kind of learning all those in the background behind the scene things that have to be done in order to get these medications approved.
Yeah, fantastic. Thanks so much for sharing, Brianna. And I'll pass to Morgan. You're back with us.
Yes. So we talked about a few different issues relating to like testing. Some patients may delay their testing, and that can be pretty tricky when you're, trying to get them started on treatment. So we just discussed some of the things that, some of the barriers there. And then we also discussed, the barriers in getting patients their treatment. everyone doesn't have access to community paramedics. So we were just trying to brainstorm possible ways that, maybe staff members, patient navigators at the sites could potentially bring the medication to the patient in a public setting. I'm just trying to be creative there. And then we have a site that does not treat currently, that from seeing some of the previous presentations saw that maybe having a PharmD be integrated into their program might be useful to get patients started with treatment. So yeah.
Fantastic. Thanks so much, Morgan. And then last but not least, final group 3, Wes and Katie.
Hi. I talked too much, so nobody really got a word in edgewise, which I'm sure everyone's shocked by. But we also kind of were discussing, issues with insurance and prior auth delays and things like that. So I think the main thing we kind of pulled from that is the most effective thing that we've tried is creating just standardized templates and keeping notes and maintaining a database of who's going to require what and what things go there. And then we also briefly touched on how to expand testing in healthcare facilities. I think we're going to talk offline about that.
Fantastic. Thank you so much to all the group facilitators for presenting on your amazing models. And I'm sure we're looking forward to hearing more from you in the August session. So we're going to be running a second webinar in late August, which will probably have more of a time for this interactive sort of brainstorming activities and opportunities sort of to learn from your peers and colleagues. A huge, huge thank you to all of our incredible presenters and facilitators today. 2.5 hours is a long time to be on a virtual call. So just really appreciate your engagement, your energy, and your time on the line learning about hepatitis C interventions and how we can sort of better implement and scale those up in our respective practice settings. A couple of housekeeping notes. So you will receive a survey from either myself or Ashley over the next sort of day or two. It's super quick and really just helps us measure what's been helpful about this training, what could be applied for next time to make it more helpful, and what your specific training needs are for the August session. So be on the lookout for that. We really appreciate your time. It should only take sort of max 2 or 3 minutes. And if you are interested in any of the INSU resources or any of the coalition resources that we spoke about, please do feel free to get in touch. My email is up there on the screen. Of course, all of them can be found on the INSU website. And we'll also be making the slides available to you all from today's session, and we'll be sending those out over the next day or two along with that survey. Otherwise, if you have any questions for either myself or any of the presenters or the facilitators today, please do feel free to get in touch. And just a huge thank you to you all. And I look forward to hopefully seeing some of you at the August session. And have a lovely rest of your afternoon all. Bye, everybody. Thank you so much.